Or somebody stole your clicker, I should say.
Yeah, maybe that was it.
All right. Bronchiectasis is defined as a chronic dilation or distortion of one or more bronchi due to excessive inflammation, key part, and destruction of the bronchial wall, cartilage, blood vessels, elastic tissue, and smooth muscle. So basically, it's a destruction of the conducting airway itself. You don't have the slide, do you?
No.
Yeah, that's why. Initially described by Laennec. Who is Laennec? Does that name ring a bell at all? Inventor of the stethoscope. He called it suppurative phlegm and dilation of the bronchi. It comes from the word bronchia, bronchial tubes, ek, out, and stasis, stretching. Literally, it's an outstretching of the bronchi. Conducting airways, correct. The etiology of it is often repeated severe pneumonias that recur over a period of years. So you have it as the source of infection repetitively. You get over one bout and it comes back for another one. A lot of the childhood vaccinations, if you're not adequately vaccinated or if you're not vaccinated, you can end up having those kind of things developing in pneumonia, which is never a good thing. But your common, not the common, but some of the community-acquired pneumonias you end up having, some fungal, mycobacteria and mycoplasma are a couple of really weird organisms that we'll talk about. But it can also occur secondary to bronchial obstruction due to some particle that or something that's inhaled and not allowed for ventilation to happen. Think of it as having repetitive situations where there's an inflammatory response that's happening in a particular portion of the lung, and that continual inflammation reduces airflow through there, and that damages the bronchial wall. Same thing can happen if I inhale something and it's just lodged there. That area distal to that portion is not going to be inflated, and that area where the occlusion happens, the bronchial wall becomes defective. There's also congenital causes of bronchiectasis to happen, and we'll see when we talk about cystic fibrosis, they often have, on top of their cystic fibrosis problem, because of the repeated infections they have, they develop bronchiectasis also. And I think I might talk about Gardner syndrome a little bit later, so I'll hold off on that one. Some people, we just don't know what exactly is causing it. Could be an autoimmune effect, and there's also some other immune-related disorders that can have a contributory component to it. I don't expect you to memorize them. Just recognize there's some other disease states that are there. Yeah. That's why I'm not worrying about it for you. Okay. Pathophysiology. It can be just on one lung, can be in both lungs. It's commonly limited to a specific lobe or segment. Usually the lower lobes or the left lingula are common. The extent to which you have damage done determines how much pathophysiology you're going to end up seeing. Some of the key parts, though, is that you have an increase in mucus production with impaired mucociliary clearance. So it's kind of like chronic bronchitis. I have a lot of mucus being produced, but I can't get rid of it. And then maybe due to the ciliary function being impaired. You also have what's called a ball valve effect. And what that means is when you inspire, your airways become larger in diameter. When you exhale, they become smaller again. So if there's an obstructive element that's there, when I inspire, I can allow air to pass around that obstruction, but when I exhale, the ball is basically blocking exhalation. So you end up with trapped gas behind it. Does that make sense?
So they can have
They have, yeah, they can have air trapping. It is an obstructive disease, so you will see reduced flow rates, and you end up having ventilation perfusion defects as your primary cause of hypoxemia. Going back, remember, we're talking about down to about the 19th generation of the conducting airways. Usually we're seeing it up much up higher in these folks. Either lobar or segmental bronchi are typically what we end up seeing. So it's higher up rather than lower down. And here's what you kind of would look like if you were to look at, this is from Netter. You guys know who Netter is? He's a fabulous artist. He's a physician who also was an artist. So he went into, he's dead. So maybe his ghost has it. Well, you're wrong right there in Philadelphia. What the hell are you doing in Philadelphia? Go ahead.
There was a big board that said Netter, and
Yeah.
later it was a medical site.
Yeah, absolutely. If well, just Google Netter. I'm sure if he has a site, it's going to be the first thing that pops up. But some of his drawings are just fabulous as far as depicting different disease states and normal states. But you can see how this ends up having these little dilation of the airways themselves, and in this case happens to have little sacs filled with pus that are there. Not a very good looking outlook. 3 types of bronchiectasis. The first one is called, well, it's not the first one you see there, but it's called cylindrical, or tubular is another word for it. And it basically just looks like tubes. Normally, the airways, as they go more distal, become narrower and narrower and narrower, right? So it's the tree. Well, this is like a tree that doesn't have, the branches are all the same width. Okay, so in this case, there's no narrowing of the airway as it goes down. The second one is called varicose, and this is characterized by a narrowing and widening and narrowing and widening of the airway in an irregular fashion. Think varicose veins. Okay. And the third one is called saccular or cystic, and as you can imagine, it looks like a sac filled with not pleasant stuff. Okay. So the airway itself just keeps dilating and dilating and dilating until it gets to the alveoli and just kind of encompassed in there. Varicose, cylindrical, or saccular, the 3 types of bronchiectasis. Technically, there are 2 other, follicular and traction, but who cares? Since our book only talks about these 3, it's all we're going to worry ourselves with. Again, varicose are dilated and constricted in a regular fashion. It's also known as fusiform. So if I use that word, because I can't just do things simply, I have to be confusing. Fusiform or varicose. And that's what you kind of end up seeing if you're looking at a CT scan. It'd be this dilation and narrowing. Cylindrical, they're dilated to pretty much a regular diameter, and they fail to taper for a few generations, and they usually have a squared end because of a mucus obstruction, or can have a mucus obstruction in the process. It doesn't really show up really well, but you can kind of see some of these cylinders that are here, where you wouldn't expect them. The last one, saccular or cystic, has basically a progressively increase in diameter until they end in a large cyst-like sacs in the lung parenchyma. This is the one that is the worst of the 3, is the saccular. The bronchial walls just become fibrotic, and they lose their elastic and cartilage, and basically they just dilate and dilate and dilate. You can see the little cysts. What's that?
If this is limited to a lobe, would a lobectomy help, or is that something that...
Can you just be quiet for a few minutes? Yes.
It's kind of a hard concept. Can we say they become fibrotic? Because we always think at least I think of fibrosis like a stiffening. But so how does it expand and not just want to continue to stay? You said it keeps dilating. How does
Yeah. Well, it's dilating in the sense that it doesn't have the normal elasticity to want to return back to its shape. It just stays inflated. Well, it is in that sense that there's a loss of elastic fibers that are there, yes. but it's characteristic of some other things involved, and the predisposing factors are definitely different. No, it's not an alveolar disease, it's an airway disease. Do you have a question, Dana? Whatever. Here's another example. You can see how big these cysts can end up getting. So what you end up seeing as far as anatomical change, there's a lot of bronchial secretions that are created, but there's not the mucociliary clearance mechanism because that bronchial wall has been damaged. Characteristically, foul-smelling mucus that usually are associated with an anaerobic growth. Never a good thing to have an anaerobic organism growing inside your lungs. Lots of mucus plugs because that mucus can't be expectorated. It ends up blocking off the airway and making inflation of that area difficult. And depending upon the size of the mucus plug, you can either have a hyperinflation secondary to that ball valve effect, or if it's large enough, you just have complete atelectasis developing. It is an obstructive lung disease, but again, because we start having a reduction in alveolar lung volumes, it's one of the few of them that can be classified as a mixed disturbance, a restrictive and an obstructive, because we lose lung volume. Normally in obstructive disease processes, your residual volume and your total lung capacity will be increased. In this one, they can actually have a decrease in those values. On physical exam, as you would expect, because of the hypoxemia, they're tachycardic and tachypnic. They're usually the typical pursed lip breathing, increased AP diameter, chronic hypoxemia leading to digital clubbing. On palpation, you would sense a lot of accessory muscle usage. Depending upon which is more prominent, the obstructive component or the restrictive component, you might have hyperresonance on percussion, you may have dullness, and you may have both in different parts of the lung. Yes?
Can a person have emphysema and bronchiectasis at the same time?
Usually, emphysema and bronchiectasis do not go hand in hand. Cystic fibrosis and bronchiectasis are quite common together.
Because all the physical examination, personal breathing,
And they're all the same, aren't they? Yeah. They present just like, and that's where the tricky part comes, in being able to differentiate between. I mean, an asthmatic probably has the same exact signs and symptoms too. So you kind of have to look at the history, and you have to look at some other key factors that are there, one of which in this case is going to be the foul-smelling sputum. That's kind of typical of this group of patients. In fact, if you I'll talk about it in a minute. Auscultation, again, crackles and rhonchi, and if you have a diminished breath sound would happen if there was a lot of airway obstructive elements. If it's a lung collapse, you then have a little bit of bronchial sounds. Chief complaint, again, is this large volume of sputum, and if you allow the sputum to actually set, it'll settle out into layers. They may have hemoptysis also, just because of the destruction of the bronchial wall, and can actually erode into the bronchial arteries that are there feeding that wall. But very thick, tenacious expectorant. They also can have chronic sinusitis and nasal polyps, and there's this one condition, this one syndrome, Gardner syndrome, which is made up of bronchiectasis, chronic sinusitis, and dextrocardia. Why the dextrocardia is in there, I'm not entirely sure, but it's kind of the three of them go together. And about a fifth of all cases of bronchiectasis are related to this Gardner syndrome. What is dextrocardia? Heart's on the wrong side. Heart be on the right side. Different than situs invertus. Right? Whatever you say, Rick. Situs invertus is where everything's turned around. So your liver is on the right, your stomach's on the left. Yeah. Your anatomy is totally backwards. Situs invertus. Okay. Which makes a problem if you're doing an EKG. You got to do a right side EKG to pick it up on All right, so what we end up seeing is kind of like the asthmatic and kind of like the COPD patient. You end up having some acute hyperventilation initially with the secondary to the hypoxemia. As they get progressively worse in their disease, they're just like a COPD patient that they develop chronic hypercarbia along with that chronic hypoxemia. And most of the problem with the oxygenation is due to shunting. They just have areas that are not optimally ventilated but are still perfused, so they would have that kind of a process going on. Pulmonary function studies, we talked about a reduction in those airflow limitations. If it's primarily an obstructive, we're going to see the RV and TLC high. If it's not, we're going to see them reduced. Okay. So it depends upon what kind of a problem is predominant. And I know that doesn't make sense, but it is what it is. On chest x-ray, again, because of the hyperinflation that might be occurring, you have a large area of the lung that is very dark in color, shading. It's dark. Flattened diaphragms. Depending upon the advanced stages of the disease, you may have right ventricular enlargement secondary to cor pulmonale. If it's more of a restrictive process that we end up seeing, we just have a lot of atelectasis. Because of atelectasis, where it's going to be much more opaque. Always want to go ahead and get a culture and sensitivity, and quite often their streptococcus, as we'll find, is the most commonly occurring community-acquired pneumonia. Haemophilus is number 2. So basically they're real prone to whatever organisms can end up being out there. And in the case of CF patients who develops bronchiectasis, they have chronic Pseudomonas infections. But again, we can also have some anaerobic mechanisms grow. We talked about sputum separating. Depending upon the extent of the disease, they may develop polycythemia. And in the case of an acute infection, which would bring them to the hospital, they would have an increased white count. If you were to do something called a bronchography, which is basically they inhale a radiopaque dye, it'll show up on x-ray and it'll identify actually the type of bronchogram that's done. Don't use that anymore. We now have got to high resolution CTs, which can identify quite easily the same kind of a thing. So it's different than a standard CT scan because it gives a little bit of a better picture as far as what's going on. But here's an air bronchogram. So what type would that be? Cylindrical or tubular. Can you see it? Don't you love this? Fluid just sitting in this dilated sac. Fusiform or varicose, right? You can see the dilation and constriction. Awareness and early identification of repetitive infections is probably the best prophylaxis, treating it aggressively. It's not as common as it was 30 years ago because our management of antibiotic use is a whole lot better. And getting childhood immunization so they don't have these other infections has reduced incidence also. Our real goal is to reduce exacerbations of the disease itself. Manage secretions. Really huge because they don't have adequate mucociliary clearance. We have to do stuff to facilitate that and reduce in the process. Then hopefully reduce the airway obstruction, and certainly if it's a chronic case, long-standing, treating the complications associated with that. So, identifying the organism if they're in acute pneumonia and treating that appropriately with the right antibiotic. They can be on a route or a regimen of inhaled corticosteroids. Again, it's an inflammatory process, so reducing the inflammation makes sense. Towards the end, they're typically on continuous oxygen just because of the chronic hypoxemia. But the real cornerstone of management for this patient is bronchial hygiene protocol. Okay, this is one of the 2 disease states that are definitively proven to have chest physiotherapy as a benefit. Okay, that's what CPT stands for, chest physiotherapy. And PD stands for postural drainage. Postural, remember the part last year where or last fall where we had you guys, know all the different lobes of the lung, and well, we're going to Mary's going to get into that about how we position patients to facilitate drainage of a specific lobe or a segment. Along with that, they need to be adequately hydrated because they have thick secretions. Again, there's that double-edged sword there towards the latter stages of this disease when they're in core pulmonale congestive heart failure. That fluid management becomes much tougher to manage. Not putting them into heart failure, but giving enough so that they're hydrated adequately. Coughing and deep breathing, and make sure they're adequately humidified. As far as aerosol therapy, these are the groups also that would work well with some mucolytic therapy, and certainly they're on typically long-term bronchodilator therapy. Candidates for the influenza vaccine as well as the pneumococcal vaccine. In severe cases, it may require bronchoscopy to actually have the scope go down and suction out that specific segment. Certainly avoidance of respiratory irritants like smoking, and if needed, as Beth pointed out, surgical resection is an option also, with saccular probably being the one that is the best success rate for it. Mild cases can live with a normal lifespan. Extensive, obviously, it's going to cut into your lifespan because it's going to affect your oxygenation ability, which is going to affect every other organ system. But that's what we typically see is the slow deteriorating process with flare-ups becoming more frequent. And that's it, right? Is that all there is on this? Is that it, or is there more slides?
There's 3 more slides, but it's like they're
Oh, they're just pictures? Okay. The incidence of, and this is that's a good question. In COPD, the use of inhaled corticosteroids actually has shown an increase in pneumonia. So someone using Spiriva, for instance, not Spiriva, Advair, can have an increase in pneumonia. Not entirely sure why that is, but it has been reported. I haven't seen that reported with bronchiectasis at all. So.